know Bill Leslie from my undergraduate days, which shows you, gives you a hint about his age too. And so he did an honors degree in mathematics and an honors degree in parallel in the extraordinarily short period of time of 3 years. I did the same thing. It took me 5. He's kind of got a zigzag education because he then zigged over to medicine and did an MD. All of these degrees are being done at the University of Manitoba. He then zagged back to computer science and did a master's degree in computer science. I don't know if he was uncertain or if he just wanted to get full share of both of them. Anyway, he then zigged back to medicine and specialized in internal medicine and nuclear medicine. And then the cherry on top of all that is he did his residency in nuclear medicine at McGill. Then came back to the University of Manitoba with appointments in the departments of medicine and radiology. And he's now the academic head of nuclear medicine section there. He's actually combined clinician and researcher, so he's clinically active in nuclear medicine and thyroid cancer. And one of his interests is what he's going to talk about today, which is fracture risk assessment. I'm afraid I don't know nearly as much about Barrett. I'm just meeting him for the first time on this project. So he's a data analyst that's working with Bill on this project and currently completing a master's in community health sciences at the University of Manitoba. So you can see the title of their talk. I won't read it, but Bill, take it away.
Yep, thank you. And as I said, I'm the warm-up act, and Barrett is the main attraction. He's got doing some wonderful work, and watch that space. This is a guy who's doing great work. So as Rob said, I've been very undecided in my career, and when I eventually grew up and decide what I'm going to do, we'll see what that looks like. But at the moment, I'm playing around with AI for medical image analysis, in particular in my area of interest, which is in osteoporosis. So I'll give you a little bit of background. I do have to give you our famous disclosure slide and the fact that we are using Manitoba health data. So you've got the disclosure there, but I'm industry free as of about 5 years ago. I also want to acknowledge that we get support from the Faculty of Medicine Radio Innovation Fund. We have a number of collaborators who are part of our original team. Barrett is a newer member of the team, and we have others that are listed there. And increasingly, we're building collaborations, so open to collaborations nationally and internationally. And I will make some reference to some of the other groups here. And Barrett will be using some of the data from some of these other collaborations. So for those of you that don't know, osteoporosis is a very common disorder. It's described as a condition where there's a reduction in bone mass, and basically the structure of bone deteriorates. It's in part age-related, but is also heritable, and there are a lot of diseases that contribute to that. So if you look to the normal bone on the left side, it doesn't take an engineering degree to know that the bone on the right side doesn't look very strong. And so the porosis or porosity of bone reflects both a reduction in the amount of bone, also the loss in structural connectivity that you see in that. So it becomes inherently a very weak structure. And that puts you at risk for fractures. Now, most people on this call have probably had a fracture at some point in their life. Most people will tell you, yeah, I know when it happened, how it happened, because it hurt like hell. And I went and got an X-ray, and they said, yeah, that's a fracture. But vertebral fractures, which I imagine nobody on this call likely has, are very different animals. These occur gradually rather than suddenly. They often result in progressive collapse of a vertebral body that can progress over days, weeks, or sometimes months. And because of that, they're usually not acutely painful, and so they often do not even become medically recognized. So anywhere from 2/3 to 90% of vertebral fractures that you can identify on imaging are actually never diagnosed because somebody goes to their doctor with back pain. So they're very common. But generally not diagnosed. if you look at statistics about how many osteoporotic or low trauma fractures occur in Canada each year, it's a pretty large number. The number of fractures, if you add up all of the common sites, of which vertebral is only one, outnumbers the number of heart attacks, strokes, and new cases of breast cancer, and it costs a couple $2 billion a year of direct costs. So it's really important. Machine learning, which of course is the focus of the talk, has only recently been applied to areas of osteoporosis. This was a systematic review that I was a part of that was recently published. We identified just under 100 machine learning and AI related papers that have appeared, and virtually all of them in the last 3 to 5 years, looking at different aspects of osteoporosis. But I'll be focusing on one of the small parts here, VF, vertebral fracture. And our studies have been contribute to some of that work. So just, what have we been doing? Well, we could give a talk on how to manage healthcare data for remote access. This is Doug's contribution majorly to the project, deep learning behind bars. So if you ever want to talk about how to set up an offline Linux repository mirror site for package management, he's your guy here. Enhanced fracture prediction models, we have a new recruit who's working on that and has done some great work. And automating abdominal aortic calcium scoring, which you can get off some of the spine imaging as well. We've just had some publications on that, and so that's of great interest because, of course, cardiovascular disease is the big killer. But I'll focus on vertebral fracture recognition because this was the first project that we got going on. And this is important because vertebral fractures are common. They contribute to identifying people at high risk for developing other fractures, including fractures like the hip fractures that will kill patients in a quarter of the situation. So we want to treat individuals who've got vertebral fractures, either because we've identified them clinically or because we've done spine imaging and we found their presence, because we know that this is the grade A population to treat with medications that can reduce fracture risk by up to 50%, which is a really dramatic reduction in recurrent fracture risk. Now, if I show you an example like this, and this is the kind of scan we'll be looking at, it's called a VFA, or vertebral fracture assessment scan, and we look at the spine from the side, and you can see we're not quite hockey pucks stacked up on one another, but in general, the vertebral bodies tend to have a fairly self-similar shape, and you can see something does not look like the others. This is a severely collapsed vertebral body, and so that's a vertebral fracture. Gee, doesn't look so hard. Why do we need machines to help us with that? Well, the reason is because sometimes it's not so obvious. So this is an example on the other side. And again, you look at these and you say, well, nothing jumps out like on the left handle, but in fact, this body's a little wedged down. There's a little depression in the superior end plate. This is a mild compression fracture. And this predicts individuals at increased risk for more fractures, for hip fractures and other adverse events, almost as strongly as finding a severe fracture. So it's really important to pick these things up. Radiologists, you would think, should be really good at this, but in fact, they're terrible at it. Partly it's because they look at chest x-rays and they're poor resolution and they see little bits of wedgie type compression everywhere. But in fact, if you get a better quality scan, you see that in fact, there are no vertebral fractures. This is the same patient. This chest x-ray, they said multiple compression fractures. In fact, when you get good quality imaging, there's nothing there. So they overcall fractures and they also undercall fractures. And there are many variants that look like deformities that are not fractures. So each of these things here, and you say, well, is that a fracture? Is this guy a fracture? Is this thing here with this big depression a fracture? And the answer is no. These are actually non-fracture deformities, and we could talk about all of these, but this one's congenital, this is congenital, and this is a Schmorl's node, which is when a part of a disc herniates into a vertebral body. So these are not fractures, in fact, even though they look very abnormal. The other thing, as I said, is that radiologists often miss fractures because they're looking for other stuff. They do a chest x-ray, no pneumonia here, do a CT, no cancer here, but they don't look at the bones. Bones get no respect. They're the Rodney Dangerfield of organs. And so you can see that this CT, which shows a fracture, this chest x-ray, which shows a fracture, these actually all predated that severe scan that I showed you that showed a fracture. But this wasn't described. So you missed opportunity for several years to have actually treated this patient to advantage. So vertebral fractures are a perfect storm, important, few symptoms, false negatives, false positives on imaging, experts disagree, and increasingly non-experts are trying to interpret these vertebral fracture imaging scans, not radiologists, not people with expertise, family docs that have a scanner like our bone density scanners in their offices. So you could ask the question, can computers do better? Well, the answer is they can't do any worse. So let's give it a shot. Harry Janant actually recently passed away, unfortunately, but he's the best known radiologist on the planet in terms of osteoporosis and vertebral fractures. When he passed away, unfortunately, he took a lifetime of wisdom with him. But if we could automate the Harry Janant method and put this on all the scanners that are in the tens, if not hundreds of thousands around the planet, to help people to do a better job at vertebral fracture identification, that would be a very good thing. So we'll talk about where our scans come from. They come off of a bone density machine, which is used to measure bone density and diagnosis osteoporosis. And we do different kinds of scans, spine scans, hip scans, forearm scans. But since 2010, we've done these scans that are specifically to identify vertebral fractures. We're actually the only province that has formal reimbursement to do this, but hopefully other provinces will, because the data we've published shows that they're very important to identify and very predictive of bad events. So our data sets here, and we have every bone density performed in Manitoba since 1990. So we have a population-based catchment. It's a single program, which is unique in Canada and internationally. And so in a last update, but soon to be updated, we had about 160,000 individual patient records with lots of linked primary and derived data elements that we pull from Manitoba Health data, and many different scan types. And in the latest iteration of this, we're getting close to 500,000 of scans, which are can be de-identified and linked with other population-based province health information. So on this particular analysis, again, I'll be focusing in on the VFA scans. Anybody that works with health data knows this kind of a slide. From up here, you can see 5 different layers of government, and that's about how many layers of permission you need if you're going to work with these things. But if you get the permissions in place, it's really like being in a candy store in terms of being able to work with these data. So this was the first project that I did since sort of coming back to the AI fold. Sheldon Durkach was a recent graduate radiologist from Toronto who had skills, and he said, I need a project. So I said, well, let's see if you can train an algorithm based upon these vertebral fracture scans to identify vertebral fractures. And I was skeptical. I thought, I don't think you can do it, but knock yourself out. You know, as you can see, this is published in Radiology, which is the top flight radiology journal. And so this tells you that we actually had some success. Since we started doing the VFA in Manitoba, we've had specific criteria for who can get them. I won't bore you with what those criteria are, but I'll tell you that the labeling is pretty crude. In our data set, there's some text, but the critical label just says yes, no, maybe. Yes, I think there's a fracture. No, I don't think there's a fracture. Or gee, I'm not quite sure. There's no localization, no severity. The only thing I can say is that the labeling is of yes, no, maybe is actually done with a very high level of accuracy, and there's a long process to take you through that. But I'm quite comfortable with the process that leads to that label. but it's, again, you're trying to localize, but all you're saying is yes, no, somewhere in the image. So in the data set that we worked with, we started off with just over 13,000 scans. We got rid of the some that the human was unable to code them as yes or no, some that were just god-awful quality, and some that had non-osteoporosis type fractures from trauma or cancer. We got rid of a few because they were incomplete, but for the training and the testing, we actually had just shy of 13,000 scans split in a fairly classical 60, 10, 30% range. And of the test set, we actually had almost 3,000 where we actually could do linkage analyses to look at future fracture events as an independent real world assessment of whether or not what we're saying is a fracture has any real meaning to the patient. So challenges in this, well, we have two different generations of scanners. In the first generation and the second generation, you can see a big increase in resolution. So these were are really a very crude pixel resolution. These are much higher pixel resolution because the different kind of architecture in the scanning. You can still see the fractures, but a heck of a lot easier to see on this image than it is in this image, and this is the same patient. And so one thing you have to do is you have to do some resampling to be able to work on a common pixel scaling. As I said, that's the same patient. I could probably sell you that there's a fracture there pretty easily. I think I'd be selling you swampland in Florida if I said this was easy. It's a difficult call, but in fact is the same fracture. The other stuff is that not all patients come looking like in the textbook. Sometimes they've got overlying artifacts that cast shadows in their scans. Sometimes they've had surgical implants, or they're wearing underwire or have bra clips and other belt buckles and things that mess up the scans. We didn't exclude those. This is real world. So in addition to identifying a needle in a haystack, a fracture somewhere in the scan, you have to overlook all of the other extraneous stuff that can make these scans really difficult to read. The architectures there, it was an ensemble of an Inception ResNet V2 pretty much out of the box, and a DenseNet scan with fairly standard architectures. We had access to the data thanks to the Doug Kimmelman's remote access and our ability to work remotely, even through the COVID pandemic, with this rig over at the Manitoba Centre for Health Policy. So this is a courtesy of Doug, but again, plug for him to do future work. And this is for Rob, an AUC, because I know how much you love AUCs, Rob. This looks at the categorization of the two different architectures and the ensemble. AUC for prediction of fracture present absence is in the test set is about 94, pretty good. How does that compare to human levels of agreement? The answer is probably is as good, if not better. If you look at kappas, which are prevalence and bias adjusted for agreement between humans, you don't find kappas that are much better than about 0.75, 0.8, even in expert hands, and much lower in non-experts or when you face humans with difficult type scans. If you look overall at performance and slice it out into age, sex, size of patient, or maybe even that generation of scanner, you can see that performance is pretty much constant across the board, which is nice. So it is robust across different cross sections of the population, and there just to show you that it's not a meaningless number, that AUC, that in fact it does correlate with the sensitivity, specificities, and accuracies that are not bad at all. Here's the real acid test. Does this predict something meaningful in the real world? So we're using a vertebral fracture detected on a scan to predict a future hip fracture, which is the ones that cost money and kill patients, or any kind of a non-vertebral fracture, including the forearms and the humerus and that kind of things. And these overlaid lines show the fracture-free survival curves for VFA negative for fracture versus positive for fracture. In the black is what is predicted by the algorithm, and in gray is what is predicted by the human. And you can see that essentially they're superimposable. That the stratification for fracture risk for non-vertebral fracture and hip fracture between human and algorithm correlates very well, and they predict really important clinical outcomes. There are heat maps that were generated and just showing some localization. These have not been quantitatively analyzed, but just were provided in the article to show that, in fact, there is some meaning to the output from the algorithm. So in this particular, and these are, of course, the cherry-picked examples, but excellent localization at 2 levels. Not every localization is nearly as good as this, but you can see that there is some meaning to what the predictions come up with. Can we generalize this beyond what I've shown you already in our data set? And that's where Barrett takes over, because of course, this is the holy grail, is generalizing so that we can do not just one kind of scan, but multiple scans, maybe x-rays and CT and MR and the whole thing. So that's the intro, and I will stop my share if I can. Shoot, where are we here, guys? There we are. Any burning questions while Barrett's getting his share going? And if not, we'll pick it up at after his talk.
I'll ask a quick one, Bill. How do you choose, if these things don't present themselves in any kind of, like, there's no pain or anything like that, how would you choose which people to actually scan in the first place?
Yeah, so of course we had to, you could do everybody, but that's inefficient because you know that young people, healthy people have such a low likelihood of finding a vertebral fracture that's just not cost effective. So when we put this together for Manitoba Health, we worked off of studies that have been published that look at the prevalence, and there are clinical markers for who is likely to have a vertebral fracture, and that is older age, people who have lower bone density, people that are on medications like steroid medications that increase your risk for vertebral fracture, and people that are losing height. So increasing height loss is a marker for vertebral fractures, which may not be painful, as I said. So those are the criteria that we used, and with that, we have about a 16% positivity rate in our scans. Which isn't bad. That's a 1 in 6 yield off doing this, and it takes about 2 minutes and is exceptionally low cost, low radiation dose. If you were to do a whole population unselected, your pickup is very low, less than 5%. So it is an enriched population, so it makes it more cost effective. Barrett, are you ready?
Can you see my slides?
Yep.
Yes.
Take it away.
Okay, great. All right, yeah, so I'm building off of a lot of great work that was done. And so I'm looking at extending the work to hologic images. And I'm going to talk about how we used active learning to improve our model performance. So there are 2 main manufacturers of VFA scanners, GE Healthcare, which Bill was describing just now, and then also Hologic. And so we know we get good performance with the GE images, but one of our main questions is, could we get the same kind of performance with Hologic? And they use different technologies. So the default scan mode on the GE Healthcare devices, they use dual energy technology, whereas Hologic uses single energy. And so you could see from the 2 images, there's quite a few differences. In particular, soft tissues appear more in the hologic. And in particular, this may cause trouble when you're looking for vertebral fractures in the upper thoracic region where the diaphragm overlaps with the vertebrae. And so as a result, convolutional neural networks that are trained on one scan mode, they may not generalize well to the other. And so in order to be able to incorporate this technology broadly into clinical workflows, we would need to automate fracture detection in both the single energy and dual energy scan modes. But it's worth noting that although the primary scan mode is dual energy in GE devices, from a single 2-minute VFA scan, you could export the image both as dual energy and single energy. Although the single energy image from GE devices looks quite a bit different than the Hologic one. And the single energy GE images, from what I understand, Bill, they're not typically used in clinical diagnosis, but we use them to increase the size of our training set. And in particular, we had a limited amount of labeled Hologic scans to work with. So this allowed us to increase the size of single energy images that we're training on. So we have two main research questions we're looking at here. What kind of performance could we get with a convolutional neural network when we're evaluating against the Hologic single energy images? And then could we train a single convolutional neural network to generalize to both single and dual energy? So for this study, we used 3 different sources of data. We used the Osteoporosis study from Switzerland, and this was limited to women 50 years or older. And Hologic VFAs were performed at 2 different time points during the study. And they were graded by 2 independent readers as part of the Osteoporosis study, and then they were regraded here in Manitoba by Bill, specifically for the purpose of our research here. But it's only 2,700 images, so it's a limited data set, and it's a random sample from a general population in Lausanne, so we have a low prevalence of fractures. Then we also have a large amount of unlabeled Hologic images, and this is from the CLSA study, Canadian men and women across Canada, but again, they are unlabeled. And then of course, we have the Manitoba data, and this is a clinical cohort, so you could see there's a larger proportion of fractures, which is great for supervised machine learning, of course, in comparison to the Osteoporosis data. And so the GE images that we have here from Manitoba, we extracted both the single and the dual energy images for training purposes. So when wanting to train a Hologic neural network, of course, we need a large amount of data. And from Osteoporosis, we just have 2,700 images. So that's a challenge. And then medical data is highly imbalanced, and which leads to poor model performance. And we do have a large amount of data from the CLSA study, but annotating data is very time consuming, of course. And also if we labeled all images, that would further increase class imbalance. So we wouldn't get much bang for a buck by labeling all of them. So in order to train up a model, we needed to acquire more labeled images, Hologic specifically, and make sure we have a good amount of fractures. So our objectives were to evaluate the ability of a convolutional neural network to detect fractures in the single energy images, but we also wanted to incorporate knowledge from the dual energy images we have and use that for single energy fracture prediction. And then we also wanted to demonstrate how we could efficiently label medical image data. So we didn't use cross-validation for our study. We split up our 3 data sets into train, validation, and test sets, depending on their size. And 60% of the CLSA unlabeled data we allocated for training purposes, and we labeled a portion of that using active learning, which I'll describe later. And then we used the Osteoporosis data, which was labeled, and we used the validation set for developing our models and for choosing our hyperparameters. And then we kept 30% for final model evaluation, and we haven't performed that yet. But it's important to note the limitations. Both of these data sets are relatively small, and they're limited to females. So I'll just talk a little bit about our methods that we chose. We used the same architecture that Bill talked about. I found DenseNet didn't work well for the single energy images, so I just used the Inception ResNet V2. We used random initialization with mini-batch gradient descent. And we used a learning rate scheduler with an initial learning rate of 10 to the minus 4. And training was conducted over 10 epochs, and our classification was done with sigmoid at a threshold of 0.5. And then again, our parameters, we chose them based on the performance against the validation data. And to reduce overfitting, we applied random image transformations during our training process. And so that included various geometric transformations as well as brightness. And we processed all our images consistently, and we resized them all to 600 by 360, and we normalized the pixel values, and then we also applied contrast enhancement. And then, of course, our data was very imbalanced, and so we dealt with that by oversampling the fractures until the class sizes were equal. I experimented with using a weighted penalty on the loss function, but I found that just oversampling worked better. And we used Keras and TensorFlow libraries, and we used NVIDIA 1080 Ti, GPUs, 2 of them. And with those, training is taking around 6 hours right now. So to measure our classification performance, we used, standard measures here: sensitivity, specificity, positive predictive, negative predictive value, AUC. And then because our data is imbalanced, we used balanced accuracy and F1 score. So this is our baseline performance before we worked on improving it through active learning and other techniques. And you could see with the small amount of labeled Hologic training data we have, we had much lower performance, of course, compared to the dual energy images. And so to improve performance, we looked at using transfer learning, where you repurpose a model trained on one task for another similar task. And by fine tuning, we pre-trained a convolutional neural network on dual energy and then retrained at a lower learning rate for Hologic, but we didn't get very good performance using this technique. What we found worked better was simultaneously training on a composite data set that included GE single energy and GE dual energy, as well as Hologic all-in-one training set. And so when we add that in, performance still isn't great, but you could see we increased the size of our training set and the diversity of it, and it did improve performance considerably from what it was. So to further improve our performance, of course, we need more Hologic images, and so we looked at using active learning to do this. So again, we had 17,000 we allocated for this unlabeled Hologic images. And using active learning, we have our pool of unlabeled Hologic images here, and we used our best model to date to select, first to predict the probability of fracture, and then we selected certain probability ranges, and those were labeled by humans. And then after the annotation, we put that data back into our training set, retrained our model, and then again went through the process. And through active learning, you could reduce the time and cost to label data, and you could obtain a good model without labeling, with labeling just a fraction of the data set, and it could also be used to reduce class imbalance. So when selecting your data, there's a number of different techniques you could use depending on your research goals. You could select the samples that the model is most uncertain about, or select underrepresented samples. But what you're essentially doing is biasing your training data to what will most likely improve model performance. And so we chose to try to increase the number of fractures in our data set and reduce class imbalance. So we randomly divided all the unlabeled hologic images into 5 equal partitions, and this allowed us to estimate positive predictive value on the previously unlabeled data throughout this process, and it allowed us to gauge our performance as we went along. And so then after each partition, we retrained our model with the newly labeled data. And so at each time point, we predicted the probability of a fracture. And depending on what we saw, we selected different predicted probability ranges throughout the process. So we first, looked at a handful of images very close to 0, and then in the upper range close to 1. And we found the model was doing very good at those extreme ranges, but where it was struggling was in the intermediate probability range. And so those are the probabilities we chose. We haven't yet completed the last iteration here, where we took our best model and looked at all the images not yet reviewed from the previous 5 partitions, and then selected all of them with a probability greater than 0.4. And in total, there's 443 images currently being reviewed. So you could see Bill's been busy over the past year labeling these images. And so we had 3 independent reviewers. Bill was our main reviewer. He reviewed all the images, and he flagged challenging cases for adjudication with 2 other reviewers. And then we used the majority decision to indicate fracture status or not. And this is how our performance has improved using active learning. So we started off again at 55% sensitivity, and we're at 80% sensitivity right now. And positive predictive value increased from 58 to 73. And so after 5 iterations, we reviewed, a pretty small fraction of all the unlabeled data, 2,600 images. That allows us to add 432 fractures. And so out of all of our data that we labeled, the proportion of fractures is 17%, which is quite good, especially compared with the low prevalence in the general population. And then regarding the generalizability of these models, we found, not surprisingly, that convolutional neural networks are sensitive to scan mode when they're trained on a scan mode that's different from what they're being evaluated on. So when we look at models here that are trained on dual energy and evaluated on single energy, or trained on single and evaluated on dual energy, you could see the performance is very poor. However, when we trained on a composite data set that was comprised of both single and dual energy images, we found it boosted performance when evaluated against single energy. So you could see it improved performance all the way across here. And so by training on a composite data set that includes the dual energy images, it seems to help the model with whatever challenges that are inherent in analyzing single energy images. It helps the model focus in on the vertebral bodies and abstract away all the image features that are irrelevant for vertebral fracture prediction. And then when we look at a composite model compared to a model that was trained on dual energy solely, the models are quite comparable. Sensitivity is a bit lower, but positive predictive value is higher for the composite model. But mostly they're comparable. So future work still to do. We have the last iteration of our active learning process to complete. And then 80% sensitivity still isn't that great. We wanted to improve that some more. And so I was looking at using snapshot ensembles. And this is an ensemble where you take a model that has the same architecture, but trained in a different epoch or across a different training run. And you ensemble those together. And I have some comparisons here. When I have an ensemble, these are all the same architecture, Inception, ResNet, V2, and I have an ensemble with 4 models, and I'm taking the maximum predicted probability from all of those. And these are the sensitivity and positive predictive value ranges of those 4 models. You could see a boosted sensitivity up by 5%, and positive predictive value increased to 81%. And you can see the improvement in the F1 score here. And then as an alternative, I created another ensemble with 6 different models, and I took the average predicted probability. And although sensitivity dropped 10%, you could see predictive probability increased all the way up to 100%. So depending on what you want to prioritize, sensitivity or positive predictive value, this may be a technique that we could use to improve performance. And then, of course, disclaimer, all these results are based on a relatively small validation set and limited to females. So we still need to evaluate on our data set that's double the size, both from the Osteoporosis study though. And we're working on getting access to an external test set with a larger population that includes males and females. So strength of our study, is that we're using fully automated fracture recognition. We're not using image segmentation. They were labeled by experienced image specialists, and we trained on 3 different cohorts, both a clinical data set and a general population. But we have to note some limitations here. Again, our validation and test sets are limited in size and in diversity. We haven't evaluated against an external data set, and we only used adjudication for the challenging cases. Most of the VFAs were reviewed just by Bill. I trust Bill, but for justification purposes, it's important to note. And then we use these performance measures to see how well our models are doing, but we didn't quantify, as Bill mentioned earlier, the location. How accurate is the location of the class activation heat map? It wasn't feasible to review all the heat maps, but it would definitely be insightful, if we were able to do that to evaluate, when a model is classifying the image properly, how accurate is the location of the fracture that it's selecting. So to summarize vertebral fracture diagnosis, vertebral fractures are commonly underdiagnosed and subject to low inter-rater reliability. But VFAs are recommended as a screening tool, and they have lower radiation, and they could be performed, while a patient is undergoing bone mineral density testing. So they're a great screening tool, and by incorporating this technology, we could potentially improve inter-rater reliability. We found that convolutional neural networks are able to identify vertebral fractures with high accuracy, and they do generalize to both scan modes if trained on a composite data set. And we also found by using a composite data set that improved our performance against the single energy scans. And active learning appears to be a great technique to reduce the cost in labeling data, and it allows us to reduce class imbalance and improve our model performance with just a fraction of the unlabeled data. So we only labeled 15% of our data, and that allowed us to add 2,500 images, 432 fractures, and boost our performance considerably. So with that, I have here a summary of our active learning stages, and we'd be happy to get some feedback and have a discussion. Here are some suggested improvements or questions you may have.
Well, the chat box is empty, so you wowed them, Barrett.
I have a few questions.
Or they're not interested.
This is great. May I ask a few questions?
Yeah.
So first, great talk, interesting work. I love these of active learning and fascinating work. So did you consider also using, in addition to the image, also using other patient data, age, BMI, previous diseases? Would that help? Would that hurt? Would that augment what you're doing?
So we did try that in the first analysis, and found that it didn't add anything. And so, as I showed you, all the patient characteristics really, the model performed equally well across those. But if you included those into it, it didn't really enhance the prediction at all. So I'm not quite sure whether we optimized the method that was for that, but it was looked at.
Okay, great. Second question, if I may. Oh, well, let me finish my question. Did you talk about having these multiple measures of balance, accuracy, and sensitivity, specificity? Taking a page from Rob's book, what about looking at expected loss? What is a penalty for every false positive? And what's a penalty for every false negative? Instead of multiple measures, you can say, for this community with this trade-off, with this cost for false positives and false negatives, I should optimize this quantity, which is the expected loss of this screening test. Well, I've asked multiple clinicians this question, and no one's ever been able to give me an answer, but I'm hoping that.
Yeah, it's very context dependent, obviously.
Of course.
And so if you're looking at a cancer screening protocol, you're pretty intolerant of false negatives, and of course that's the problem with mammography is very, very low positive predictive values because the sensitivity is so high. In this situation, and this is my thing, is osteoporosis, and in fact I'm currently chairing the Osteoporosis Canada Guidelines update, and I chaired the 2010 guidelines. I actually haven't thought that one through. The harm of a false positive is relatively small, maybe unnecessary treatment. But since everybody benefits from treatment with some degree of risk reduction, the treatments are generally well tolerated and inexpensive. It's not a big penalty to pay for that. So I don't see obviously I don't want to treat unnecessarily. So it might actually be that it's that there's a balanced trade-off as I talk myself through this. I don't really know, but it's certainly not like the cancer scenario. There was a question here about fracture location. By fracture location, we mean which vertebral body, which level. And so for those that don't know, that typically osteoporotic fractures occur in the thoracic spine from T4 down to T12, or in the lumbar spine from L1 to, usually they say L4, but L4 to L5. So by level, we mean that anatomic level in the spine where the fracture occurs.
If you just showed them one at a time instead of, like, can you actually cut this image into individual pieces and then classify them one at a time? That automatically gets you localization.
It does. That's an approach that there's a company in Israel called Zebra that is monetizing and commercializing AI methods, and they've actually got one product out there which is supposed to work in the background on CT scans and do sort of post hoc overnight analysis of CT scans to identify vertebral fractures. Anyway, the architecture that they used used recurrent CNNs, and it isolates the vertebral levels and analyzes them separately, sort of similar to what you're talking about, Rob. The challenge is that there's a lot of important context information looking at the whole spine together that humans use. So the vertebral bodies, as I said, are not hockey pucks. And so there's actually a smooth transition in shape as you go from upper to lower. So a shape that's in the lumbar spine that you might say that's just normal, sort of a smooth, dishy shape to the top and the bottom, would not be a normal shape in the thoracic spine. Because we have normal curvature. And so that normal curvature is in part related to normal change in shape as you move down the spine from top to bottom. And typically fractures don't occur uniformly throughout the spine. They'll hit one level, and then there's a skip, and then hits another level, then a skip. And so that they're marked by marked heterogeneity. And so probably if you were to chop it up into a whole bunch of individual vertebral bodies and look at those individually, my guess is that might actually perform worse than being able to do a Gestalt look at the whole spine at one go. Certainly, as a human reader, it's it's looking at a whole spine like that. It's like instant pattern recognition, and so. I'm not sure. It's obviously anthropomorphizing. Barrett, do you have any thoughts about that?
I don't. I mean, it's something we haven't tried.
There's a question here about the split 60, 10, 30. And they said from our limited experience, maybe the validation percentage would be greater. I'm not sure. From my limited experience, sort of 60, 30, 10 is what I see commonly used, or 60, 10, 30. But I'm happy to say if there's a better way to do it that gives us more power for the test set, that would be great.
Yeah, because we are quite limited here for validation and test set. The question was suggesting what, Bill? I don't have access to the comments here.
Yeah, it just said, why did you pick 60, 10, 30 for training validation test? And it seems to be wisdom of the crowd at this point in terms of what you try, and if it works, then that's the proof.
Yeah, I mean, you need a good amount of training data, obviously to get good performance. So it's a balance between that and having a good data set that's generalizable. So.
Yeah, if I didn't have a day job, I could do all 28,000 CLSA scans for you. But I tell you, this is it is a lot of work when you say that there's a cost to the labeling, yeah, it's largely my weekends.
Yeah, I'm not sure who spent more time on this project, me or Bill.
Did you try to stratify the split so that you had, like, let's say there was, I don't know, 5% fractures? Did you try to get 5% in each of the groups?
No, so it was a random split, but through randomization, it all equaled itself out.
So that's only true if you average enough times.
Yeah, well, it turned out, be pretty equal. But that's a good point for sure.
Are there any other questions? There's one. Oh, no, that's a thank you.
I had one. I wrote this: how to measure the incorrect fracture localization quantitatively. So, as Bill mentioned that, okay, you want to identify at which particular vertebra you have that fraction. So you want to segment it out and then measure how closely it resembles to the labeled, manually labeled fracture, or what is the criteria to compare against.
Yeah.
Since you are using active learning, I'm assuming that you don't want the entire data set to be annotated, right?
So we did label, each individual level, where the fracture was. So whether it was on, L5, L4, L3, or L2.
Mm-hmm.
And if we had, a large enough data set, we could break down our performance by fracture location and severity. But so the idea would be, if we went through all of these and saw that the heat map here, is that L2, Bill?
It's my guess is it's probably 5, 4, 3, 2, 1, probably 12.
Okay.
Because, yeah, it looks like you got a 5 just below the pelvic crest.
Okay. But so, if the model here you could see is activating on this vertebral body here, then we would compare that to, when Bill labeled the data set, and did he mark this one or this one, and then we could compare the accuracy of the
Okay. All right. So you just want to compare whether it was where it was marked or not the exact area that. Okay, I got you.
Yeah.
I had one quick question. So I forgot. Sorry for this. That if you use fully convolutional neural networks here or not, and if you used, what was the complexity of this algorithm? That given one scan or one image, how quickly you can test it in real time once you are trained it.
Okay. So by complexity, I mean, the model has 54 million trainable parameters. I don't know if that's what you're referring to.
Yeah, I mean,
so let's say you have trained the model and you know
Yeah.
you want to deploy it in the clinic. So how long will it take for one image to produce the output that you want out of it?
Yeah. So I mean, the training time is quite long, 6 hours, and it takes a couple minutes to load up the model into memory. But once the model's loaded up, in, I don't know, I'd say 30 seconds, not even, probably.
Okay.
I think it takes about 10 to 15 seconds to make a prediction on an image.
Awesome.
Yeah.
Yeah, it was a wonderful presentation.
Well, sorry, I should say 10 to 15 seconds to make a prediction on the entire validation set. So a single image would be a lot quicker than that.
Yeah, I was going to say if single forward pass through this is fast.
Yeah.
Awesome. Great.
I've got to go myself, but I think Bill and Barrett might also be meeting with some people after this talk. So I think we should cut it off at this point. It was an absolutely wonderful presentation. So thank you, Bill and Barrett, for your contributions.
Thanks, Rob. Thanks, everyone.
Thanks for having us.
It was a pleasure.
Yeah.
Thank you very much.
Thank you for a wonderful presentation.
Hi, Bill. I didn't have anybody contact me beforehand to say that they wanted to meet with you guys right after. So I don't know if, I don't know if anybody has messaged you during or privately or anything.
Not yet. There's still a few people on, so I'm not sure if they're